Very good evening to all of you. I welcome you all to the last session of the second cycle of Neuromuscular SIG. As we told earlier, we have been having sessions every fortnight now. And this is the third session of the Neuromuscular SIG. I request our President, Dr. Shafali ma'am, to introduce the speaker, the topic for today, and the experts for today's session. Over to you, ma'am.
Thank you. Thank you so much. I welcome you back. And Asmita, can I have the slides, please? So today we'll be talking on childhood. And the speaker of the day is Dr. Manoj Menzies, who is world-renowned in neuromuscular disorders with very much special for neuropathies as well. And he's going to be talking on measuring, managing, and modifying childhood CMT. And he's clinical associate professor, Children's Hospital at Westmead Clinical School, University of Sydney. And he is a co-lead for Neuropathology Research Group and Kids Neuroscience Center and Children's Hospital at Westmead, and president of the Australia and New Zealand Child Neurology Society. And we are really grateful that he has joined from Australia. With his time right now is 12:30 a.m. And he'll be there from 12:30 a.m. to 2 a.m. We're really grateful, Dr. Manoj. And as per protocol, we'll be having two experts. And Dr. Professor Maya Thomas is Professor and Head of Pediatric Neurology, Department of Neurological Sciences, Christian Medical College, Vellore, Tamil Nadu. And she's very well renowned. And we have to complement an adult neurologist who is a very, very big name for neuromuscular disorders. Besides being a very well-renowned neurologist, she has focused on neuromuscular disorders. That's Dr. Nalini, and she's professor of neurology and the former head neuromuscular specialist, lead NIMHANS in the Advanced Center for Neuromuscular Disorders. And she has been awarded very many awards and has been a task force member for ICMR for Rare Disorders Consortium Gene Therapies. And she's a fellow of Indian Academy of Neurology and executive member Asian Oceanian Myology Center, and was awarded the Sir C.V. Raman Young Medical Scientist Award. And to moderate the session this time is going to be Dr. Mahesh Kamate, our secretary, who you all very well know, and who was the first DM pediatric neurology from our institute 20 years back. And because we've completed 2 decades of DM pediatric neurology. Here, over to you, Mahesh. And after this, we will be having 6 case presentations. And this time, because we got 6 cases and we didn't want to refuse, so we've requested everybody to have only 5 slides and with important messages, 5 minutes each, because we have to cover, and we'll be covering from 9 to 9:30. Mahesh.
Yes. Without much delay, I request Dr. Manoj manages to go into this talk. Over to you, Dr. Manoj. And share your slides.
All right. I hope you can all see my slides there.
Yeah, clear.
Can I start by thanking the AOCN and Professor Gulati for inviting me to talk today, and I'd also like to say hello to the experts. I met Professor Thomas at the wonderful AOCN conference in February this year, and I've known Professor Nalini for a long time because of our shared interest in neuropathy. So my talk today is titled Measuring, Managing, and Modifying CMT or Charcot-Marie-Tooth Disease. Now, to give you an overview of what I'm going to talk about, we all know childhood neuropathy may be acquired, Guillain-Barré syndrome and CIDP, or inherited. And inherited, we often like to subdivide into those that are predominantly a sensory and motor peripheral neuropathy. We call the Charcot-Marie-Tooth disease or CMT, and other syndromic, where the neuropathy is part of a larger multisystemic involvement. These may be complex genetic syndromes, for example, the neuropathy that you see in Cockayne syndrome, or metabolic, which is the neuropathy, for example, that you may see in metachromatic leukodystrophy. For today's talk, I'll be concentrating mainly on CMT. So today I'll give you all an introduction to CMT. That part may be known to many of you who are experts in neuromuscular disorders. I'll then move on to our interest in measuring function and disability in CMT, and I'll talk about the CMT pediatric scale and the CMT infant scale, And finally, I'll end by talking about managing and modifying CMT, where I'll talk about our recently published CMT clinical practice guidelines, whether BMI has an effect in CMT, and some exciting new disease-modifying therapies for CMT. So what is CMT? It's an eponymous syndrome named after these three gentlemen who provided early descriptions of the peripheral neuropathy: Jean-Marie Charcot, Pierre-Marie, and Howard H. Tooth a century and a half ago. CMT is characterized by distal weakness and wasting, so foot deformity, upper limb weakness, sensory loss. And we classify CMT based on whether it predominantly involves the myelin. So there's demyelination, we call that CMT1, or if there is predominantly axonal involvement, and we call that CMT2. Now, we all understand that CMT is a length-dependent neuropathy. And what that means is that the ends of the longest nerves are affected first. So the feet are affected before the hands. And the phenotype, again, as shown here by this adolescent with CMT, is the very classical distal weakness causing foot drop, distal wasting, foot deformity, sensory loss, and loss of reflexes. People like to classify CMT or divide it into groups where there is predominantly sensory involvement, and there are genetic syndromes in pediatrics that have predominantly sensory involvement, and these are called the hereditary sensory and autonomic neuropathies, or those where there is predominantly motor involvement, and these are called the hereditary motor neuropathies or the distal hereditary motor neuropathies, as well as hereditary motor and sensory neuropathy that is involvement of both sensory and motor nerves. For the purpose of this talk, we will classify everything into one group called CMT. Now, there is a gene for CMT on every chromosome, including the mitochondrial genome, and now we are up to 100 different loci for CMT. So how do we break it down and direct genetic testing? Well, first, we try to differentiate from an acquired neuropathy. CMT usually has a chronic but slowly progressive course without fluctuations. Foot deformity is very common in CMT, uncommon in acquired neuropathy. And there are classical nerve conduction findings, those of a length-dependent neuropathy and uniform slowing in CMT, while you may get conduction block and temporal dispersion in acquired neuropathies. You then try to identify the inheritance. It may be dominant, recessive, or sporadic. You then use nerve conduction studies to identify whether it is CMT1 or CMT2. And you look for phenotypic clues: early onset scoliosis in CMT, 4C, upper limb involvement in CMT2D, and this will help you direct your genetic testing. Now, you must remember, compared to adults, you need norms for your nerve conduction studies in childhood. You can see in this picture here on the left that myelination and hence conduction velocity in the peripheral nerves increases quite dramatically in the first 4 years of life. We use the norms here, published by Boston. You may have specific norms for your own labs. And there are other norms available that look also at F waves or at nerve conduction studies in the very young. This had a bit of interest when I presented it at the AOCN. We use nitrous oxide for sedation of our children while performing nerve conduction studies. And this allows us to have conscious sedation and for children to tolerate quite extensive nerve conduction studies without the need for using, for example, general anesthetic. Again, remember there is genetic heterogeneity in CMT. The same gene may cause a predominantly motor form or hereditary motor neuropathy or hereditary motor and sensory axonal neuropathy. And rarely genes can cause both demyelinating and axonal CMT. differing only by the age of onset. So what's the genetic profile of childhood neuropathy? When we looked at our group, we had a predominantly demyelinating form of CMT, which is around 85% of our group, and a smaller number was CMT2. And out of these, we achieved a higher diagnosis rate in CMT1 and only around 50% in CMT2, which reflects those of other adult and pediatric cohorts worldwide. And what were the common genes out of the total cohort? We had 4 genes, 5 loci that were most commonly associated with CMT. This included deletions and duplications of PMP22 causing CMT1A or point mutations causing CMT1E, CMTX1, which is X-linked CMT, CMT4C, and mitofusin, which was the most common axonal form. We also have a few families causing CMTX3. And these are the genes that you will also need to understand well, because all other forms of CMT are very rare and make up less than 1% of total cohorts, though in some locations you might have a slightly higher prevalence of the recessive forms depending on the ethnic makeup of the area that you practice. All right, that was just a brief introduction into CMT. Now I'd like to go on to the first part of my talk, which deals with measuring CMT and 2 of the scales that we use, the CMT pediatric scale and the CMT infant scale. Now, it is important to measure both function and disability in CMT. And we have a suite of measures to measure outcomes throughout life. We use the CMT infant scale, and that measures function and disability in the first 4 years of life. We have the CMT pediatric scale to measure outcomes between 3 and 18 years of age. And in adults, we have developed the CMT form as well as the long-standing CMT neuropathy score version 2 rash modified. I'll speak about the first 2 in this talk. So why should you measure disability in CMT? Firstly, an understanding of the disability and progression of each genetic subtype of CMT allows you to provide an accurate prognosis to the family, and hence to put in intervention at the age at which progression is most likely to occur. It's also important to correlate change in functions with symptoms reported by the family. For example, if a family reports or the child reports significant fatigue or significant pain, you want to correlate and see if that is because of a progression of their CMT and decline in function. You could use these outcome measures to determine what interventions might be most beneficial to that child. As I will show you, these scales have sub-items that look at different functions, sensory function, balance, or strength. And hence, if a child has predominant problems with their functional dexterity in their hands, you will get an occupational therapist to help them with hand function. If they have significant problems with their balance, you might try one of the balance training methodologies with your physiotherapist. Once you have put these interventions, especially significant ones like surgery, you should be able to use one of these outcome measures to evaluate the benefit from that intervention. And finally, and very importantly, these will be used as outcome measures in clinical trials of some very nice disease-modifying therapies that we are expected to be available to us in the next decade or so. So the first scale that we commonly use is the CMT pediatric scale. We run a peripheral neuropathy management clinic where we see children between every 1 to 3 years, depending on the severity of their CMT, and they get a CMT pediatric scale assessment at every visit. It takes around half an hour to test the outcome measure for a single child. Now, our CMT pediatric scale consists of 11 sub-items. The first two are those for hand dexterity, and we use the functional dexterity test and the 9-hole peg test. We then measure strength, that may be, that is hand grip, plantar flexion, and foot dorsiflexion strength using a dynamometer. And then we measure balance, we measure sensation using vibration and pinprick. And finally, balance, gait, long jump, and a 6-minute walk distance. Now, these are 11 sub-items. Each, the score that you get, the raw score, is compared with the age and sex match norms to give you a Z score or a standard deviation score. And that will go from 0, which is meeting the normative, to 4, which is 4 or more standard deviations below. And these scores are then combined to give you a total score of between 0 and 44. 0 is unaffected or similar to typically developing children of that age and sex, and 44 is very severely affected. So let's look at 2 cases and the benefit of using the CMT pediatric scale. So this was a child who had presented to us quite early because of a family history of CMT1A. Her father also had CMT1A. She presented to us at 4, though her first CMT pediatric scale measurement was only at 10. And you can see here, her first score was 14 in the moderate range. But this is her at transition, so discharged to an adult clinic at 18 years of age. And you can see, even though she has CMT1A, it's very hard to fault her gait. It is only when you ask her to walk on her heels that you see that she has an issue. And this is paralleled by her CMT pediatric scale assessment there, which shows that even over time, as expected for CMT1A, she has progressed very little. So around 5 points in 6 years, which is less than a point per year on the CMT pediatric scale. Now let's contrast that with someone with a more severe form of CMT. So this boy has CMT4C. He presented early in childhood, went on to develop significant hand weakness at 6 years of age. There was a deterioration in his gait with wheelchair use at 6 years, and he was non-ambulant and continuously using the wheelchair at 14. He had spine surgery at 14 years of age and had respiratory dysfunction at 17. So you can see his CMT pediatric scale assessment here. In early childhood, he was in the mild range, but he progressed rapidly on the scale over the next 10 years or so. And this apparent stabilization is only because there was a ceiling effect on the scale. So you can see the CMT pediatric scale nicely captures the progression of different forms of CMT. We also have the CMT infant scale to use in the very young children with CMT. And now, because of advances in genetic technology, we are identifying children with CMT very early, either because of a family history or easy access to genetic testing. And so for these children, we use the CMT infant scale. A lot of this scale is based on getting the children to do various activities and scoring them. And these may include things like their ability to sit, crawl, point, scribble, or tear paper. And you get a total score again compared to age and sex match norms. So hopefully I've interested some of you in using these scales in your day-to-day practice and hopefully in time for clinical trials. Please visit the clinicaloutcomemeasures.org website. Here you will see information on the CMT pediatric scale. There are modules on how to use each of these scales, as well as calculators. You can do the test on your child, input the value. It will give you a Z score based on age and sex match norms, and a total score and an easy printout that you can add to the child's file. And of course, we also have our 1,000 norms, which are the norms that we use for all these scales. So what have we seen as a baseline for use as the baseline for clinical trials? So we looked in a very large international cohort of the Inherited Neuropathies Consortium at the rate of progression on the CMT pediatric scale. Out of the total group, and that's the difference of the change in score over 2 years, the whole group changed at the rate of 2.4 points over 2 years of age. CMT1A, as expected, was the mildest, progressing less than a point per year, so 1.8 points over 2 years. Now let's compare that with other more expectedly more severe forms of CMT. You can see CMT2A, and in your experience, you would have seen many of these children will be using a wheelchair by the second or third decades of life, progressed at 6.2 points, so 3 times the rate of progression of CMT1A. So the same progression with CMT2D due to GAS mutations. And children with CMT4C again had at least double the rate of progression of their CMT. So look, I'll stop there for the first part of the talk. Maybe I'll ask the moderators if we want to take some questions now on this part before I go on to the part on managing and modifying CMT.
Manoj, we can continue actually. We'll finish
Okay.
and then take the questions. Yeah.
Okay, I'll do that. Thank you. We all, a few of us clinicians in the Asia-Oceania region are members of the Asia-Oceania Inherited Neuropathies Consortium. So if you have a specific interest in inherited neuropathies, then please consider joining the AOINC. And we're very eager to work with groups like the AONC and to promote both education, but also especially research collaboration across the Asia-Oceania region in inherited neuropathies. All right, coming back to our day-to-day practice, I'll talk about managing and modifying CMT. While we cannot cure most CMTs at this time, I would like to convince you that all inherited neuropathies are treatable. And I'll talk about our recently published pediatric CMT management guidelines and a little bit of the relationship of the BMI with CMT progression. And then I'd like to talk about some early exciting developments in cures for CMT. So recently we have published some clinical practice guidelines for the management of pediatric CMT, and these were not available previously. And we organized these as part of a modified Delphi methodology using experts internationally, and that comprised both of doctors working with neuromuscular disorders, both pediatric and adolescent, as well as allied health professionals, including occupational therapists, physiotherapists, and podiatrists. We also had the surgeons involved. So we came up with 3 evidence-based and 31 consensus-based recommendations for the management of CMT. And overall, our group was called the CMT Best Practice Guidelines Consortium. The first guideline was based on a study we had done of the safety and efficacy of progressive resistance exercise training. And we did a randomized control study of progressive resistance exercise for ankle dorsiflexors. And we used 6 months of targeted exercise for ankle dorsiflexors. And what we saw that at 24 months, the group that had the active intervention had slower progression of their ankle dorsiflexion weakness than those in the sham group. And there was absolutely no concern of ankle dorsiflexion weakness. So the first clinical practice guideline is based on this study, and it says that we recommend the use of progressive resistance exercise of the ankle dorsiflexion to improve muscle strength and slow the progression of muscle weakness. So what this tells you is a tick or a yes for exercise for various forms of CMT, and a no for vitamin C. There was early a lot of interest in vitamin C, but we and others have shown that it is not effective. And again, we have had trials at our group showing that Botox is not useful for managing contractures in CMT. We also recommend aerobic type exercises to maintain proximal strength in CMT. Ankle contractures and reduced joint range, especially of the ankle, sometimes in the upper limb, is a significant problem in CMT. A consensus-based guideline is that stretching of joints prone to contracture should be a part of rehabilitation management, but the only effective intervention is serial casting. I'd like to know how many groups here do use serial casting. We use it very frequently, both for our children with muscular dystrophies and CMT, where we put on casts in which they can walk in and progressively tighten these casts over a 3 or a 6 week period, changing the casts twice a week or once a week, and hence progressively increasing their joint range. And after that, they get bed resting AFOs or night splints to maintain that range. So we recommend that serial casting should be used to improve the ankle dorsiflexion range of motion in children who have restricted joint ranges. What treatment should be recommended for impaired mobility in carefully selected children who have the following? So foot drop, you saw the video of that child there with CMT with significant ankle dorsiflexion weakness, and where the weakness causes trips and falls or ankle instability, then ankle foot orthoses are very useful in improving the gait. We use a whole range of AFOs, including solid AFOs, hinged AFOs, leaf spring or carbon fiber AFOs, and we have a project on 3D printing of AFOs now. When should you refer to an orthopedic surgeon? So we have some guidelines here on referral to orthopedic surgery. If a child has painful, disabling, or progressive pes cavus that doesn't respond to conservative management, so either AFOs or in-shoe orthosis, severe ankle contractures affecting gait that is not responsive to stretching intervention. Hip dysplasia, interestingly, seen in 10% of children with CMT, and it's not always related to the severity of the CMT. And we recommend a biennial hip X-ray. And if there are features of hip dysplasia, children need to go and see this orthopedic surgeon. And finally, a number of forms of CMT have scoliosis. And if you have features of moderate scoliosis, you need to go and see an orthopedic surgeon. The final guideline that I'll talk to is a referral to a respiratory surgeon whenever there are features of sleep disordered breathing, yes. So early morning headaches, daytime somnolence, when your FVC is less than 60% of age, when there's a significant scoliosis, or in non-ambulant children for more severe forms of CMT, like you saw with CMT2A or mitofusine, then yes, these children should see a respiratory physician, and after a sleep study should be considered for the use of non-invasive ventilation. So that's a selection of the guidelines. I'll refer you to the whole paper that deals with other things, including rehab interventions. And if people cannot access the paper, please just email me and I will send you a copy. All right, this is the work of a PhD, Dr. Don Levy, in a group, and she looked at the association between BMI and disability in CMT. Usually, when we have children with neuromuscular disorders, we worry about the ones that are put on a lot of weight and are obese. What she found, and again, I'll explain this graph here. You remember the CMT pediatric scale that I talked about: 0, unaffected, 44, more severely affected. And we grouped around 400 children from the Inherited Neuropathies Consortium with CMT into 5 IOTF groups here on the x-axis. And what we saw was it was the ones that were severely underweight and the ones that were obese that had the most significant disability compared to those of healthy weight right here in the middle. So that was at baseline, but what happens over time? Again, when you looked at the whole cohort, those were severely underweight actually progressed more rapidly than those of a healthy weight. When you saw those whose BMI had remained stable over a 2-year period, even among those, the ones that were severely underweight at baseline and the ones that were obese at baseline had more rapid progression of their CMT. So this is not an intervention study, but provides some interesting early evidence that management of BMI with either good nutrition, or with exercise may help modify the disability from CMT. All right, now I'll come on to some research being done worldwide on disease-modifying therapies for CMT. The first 2 are progress that's been done in adult forms of CMT, so not pediatric forms, but still interesting to see interventions making a difference for individuals with CMT. The first is SORD neuropathy. In many of your labs, you would have identified patients with SORD over the last couple of years since the gene was described by Andrea Cortese in 2020. And this is an interesting neuropathy. It's a, could call it a metabolic neuropathy, though it presents as CMT, where there is intracellular accumulation of sorbitol due to mutations in the sorbitol dehydrogenase gene. And these individuals have raised fasting serum sorbitol. And Andrea also in that paper showed that use of aldolase reductase inhibitors actually normalizes this intracellular sorbitol both in the fruit fly and in patient fibroblasts. And based on this, there is a trial running in the US run by Applied Therapeutics. And I just saw a month or so ago that they had applied to the FDA for accelerated approval for their aldolase reductase. This is drug repurposing in a new way because a number of aldolase reductase inhibitors are already available for treatment in diabetes. L-serine, easily available supplement, has been around for a while. May be effective in individuals with hereditary sensory and autonomic neuropathy, usually presents in late adolescence or early adulthood, and it's due to mutations in the SPLECT1 and SPLECT2 genes. And these are involved in insertion of serine into your sphingolipids. Abnormalities in this gene causes the accumulation of neurotoxic deoxysphingolipids, which are toxic to the sensory ganglia. It's been shown that L-serine causes a reduction in these toxic deoxysphingolipids, and Vera Friedman's trial showed that high-dose L-serine supplementation caused improvement both in the CMT neuropathy score as well as deoxysphingonine levels. Now, work is being done to find out good outcome measures for this group because unlike most other forms, it's predominantly a sensory form before there is a larger worldwide trial of L-serine supplementation. So 2 very promising interventions. The third I'm going to talk about has not been so promising, and that's PXT3003 some early promise, and this is a combination of low-dose sorbitol, baclofen, and naltrexone. Now, in time, it's become interesting that it includes sorbitol because now we know it's toxic to your motor neurons. Initially, they had shown that this causes a reduction in the PMP22 mRNA. Now, in CMT1A, we know it's due to a duplication of your PMP22 genes, so you have too much PMP22. So what you want to do is get medications that cause a reduction in the PMP22. So this molecule had shown a reduction on PMP22 mRNA expression in rats, and in a phase 2 study showed a reduction in the scale that they had used, the ONLS, in the high dose group. In the phase 3 study, they did show an improvement in the high dose group, but there were problems because of crystallization of the study drug, which removed blinding. And hence the EMA asked them to do a second phase 3 study, which unfortunately showed an improvement in both the treatment and the placebo arms, and the results were not significant. So it doesn't look like this molecule will go ahead as a treatment for CMT. Now, this is, I think, what we are all looking forward to, and that's gene replacement therapies. CMT, and especially childhood CMT, is probably the group that is the best fit for trying some of these genetic replacement therapies. You are born with the same number of neurons that you will have for the rest of your life. So they're not actively dividing. They're easily accessible by means of intrathecal administration. So genetic replacement technologies hold a lot of promise for children with the various forms of CMT. So Cleopas group has shown benefit in rats and mice of gene replacement in CMT-X1, CMT4C, and CMT4J, all demyelinating forms of CMT. Nationwide Children's Hospital in Ohio is actually running a trial for gene replacement therapy in children with IgHM-BP2 mutations. These cause either a severe form of progressive neuropathy called SMARD, or a less severe progressive form called CMT2X. So I think they have recruited around 6 children for their trial. So we eagerly await those results too. But I think you will all see a lot of movement in this space over the next decade. So look, that's the end of my talk. I have talked about both ways of measuring disability in CMT, as well as ways to manage and modify CMT. So I'll conclude by saying, firstly, measuring disability in children with CMT is a useful adjunct to your clinical management of these children with CMT. As I showed you, there are an increasing number of disease-modifying and gene replacement therapy that are available both in clinical and preclinical development. And the recently published pediatric CMT management guidelines provide a useful framework for the day-to-day management of CMT. Finally, I'd like to invite all of you to our pediatric neurology conference that will be held in beautiful Queenstown in New Zealand. So if you want to hear some good science, or you just want to ski, come and join us down in Queenstown. And finally, I'll thank everyone in our group that has done the work that I talked about today, and especially the children and the families who contribute so much of their time in helping us with this research. There's my email address down there. And if you'd like to discuss interesting cases or collaborate, please feel free to drop me an email. And finally, I'll end there and happy to take any questions.
Thank you, Dr. Manoj, for the wonderful talk. Before we take questions, I would request comments from our experts, Dr. Nalin Madam, followed by Dr. Maya.
Thank you, Dr. Manoj. It's really a very informative talk and something different from the usual presentations. Of course, I see a lot of pediatric, right from infants to as old as 90 years, and there's no sort of cutoff for us. But I really like the scales. I just want to ask you, the scales are administered by experts, clinicians, or physiotherapists? Who are the people who administer these scales for your patients?
Really, anyone can be trained to use the scale. Over the next year or so, we are developing a platform for training individuals to administer the scale, and then for certifying, there's no cost to it, but we're just making sure everyone is well trained. For example, in our lab, one of our clinic coordinators is a dietitian who had done the work on the BMI, but she's been trained to administer the scale. We have medical students who are doing their PhDs who do the scale. And of course, physiotherapists would be able to do that very easily. So if you have allied health physicians working in your clinic, then they're probably the best currently trained people. But really, it's not that complex scale. The equipment is not that costly. So anybody can be trained to use it. But if you have physios, it's probably easiest to get them to administer the scales.
Thank you. Thank you. And are you undertaking any drug trial currently in your department?
Not for CMT. We have been involved both with the Pfizer and the Sarepta trials for gene replacement in Duchenne muscular dystrophy. I don't think there are any CMT gene replacement trials running anywhere except for Ohio. It's been challenging there at Nationwide because SMART and CMT2X have such a wide phenotype. So to compare the benefit of gene replacement is challenging when I've spoken to Anne Collinley and Megan there, but they are the initial leaders, and I think we'll all follow. And of course, remember SMA, in which gene replacement therapy has been so successful. You know, all of you have cases. Professor Gulati has a huge number, is again a neuronopathy, so same spectrum as CMT. So that's why I think it holds such promise. But at the moment, we don't have any, but I don't think it'll be a long time till we do.
So thank you. Thank you once again for that wonderful talk. Really learned a lot. Dr. Maya, please.
Thank you, Dr. Manoj. Excellent work, as always. And see, one of the other you mentioned about lower limb physiotherapy and mobility. The one other problem which we commonly encounter is hand functions. So what is the way for, because children especially in our country, this computer-based learning is not so not taken off so much. So there's a lot of written work, and so any kind of kind of guidelines for hand functions.
Yeah, actually, that's a very important thing to target in children. That's probably makes the most difference to the children in their day-to-day work. As you know, their cognitive abilities in most forms of CMT is unaffected. So the challenge is getting all that knowledge onto the paper. It's not only for you, even for us, our education board is very resistant to allowing the use of computers in exams for children in high school. So what do? We use the CMT pediatric scale to measure their hand function. There's hand dexterity and the 9-hole peg test, and our OTs do a handwriting assessment there. What are the interventions that we use? They do prescribe hand exercises, but these are simple ones for their using, for example, hand putty. Secondly, we use splints. We use soft neoprene splints that they use for their regular work, just provide a little bit of stability around these joints. Otherwise, one of the main problem is both proprioception and hypotonia. So they provide bit stability, and to prevent contractures, we then have more hard splints that they wear at night. We have not found any benefit from surgical interventions in the hand, so please don't go ahead and do those. And then based on the handwriting assessment, we write to the school asking for rest breaks as well as increased time for the exams. And we advocate very strongly for the use of a computer. So those are the interventions that we use for upper limb dysfunction. Our OTs have a very, very important role in our peripheral neuropathy management clinic.
Well, thank you. Also, this testing for these hereditary neuropathies, as there is a tendency to get negative genetic reports. So, would you do a whole exome first, or would you do like a multi-gene panel? What is how do you all go about?
Yeah, that's an important question, and one that we think about very well. So I think irrespective of whatever genetic technology you have available, and I know genetic testing is actually more easily available in India than it is available to us. I was amazed at the quality of the testing and the quality of the reports available. Please make sure that you phenotype the child well, because you do need that phenotyping. And I think every child should have a nerve conduction study unless there is a family history of a known gene. You have to phenotype them well, do the nerve conduction study. Then, if we are quite confident in the phenotype, we know that this is CMT, we go for a panel. Now, our panels are based on an exome. They're not true site panels, they're exome-based panels. But looking at a small number of genes gives you a much better results with very few variants of uncertain significance for your CMT, and you'll find a cause. If you have axonal CMT, your hit rate's still around 50%. Demyelinating CMT is much higher, probably around 80%. So we always use a CMT based panel initially. If that is not, and then we segregate using parental samples to make sure it's de novo or recessive. If we don't find a cause, we then move on to whole exome sequencing that may be research or clinical. And finally, our research labs have access to whole genome sequencing. Remember, some of the panels are still not good at picking up deletions and duplications. So use a chromosomal microarray and MLPA to pick up the CMT1A. But if you're phenotyped well, you're confident it's CMT, I would advocate using a CMT panel and then moving on to trio whole exome if it is negative. If your phenotyping is broader, you see someone, they have intellectual disability, autism, some upper motor neuron signs in addition to a peripheral neuropathy, then I would advocate going down the pathway of using a trio whole exome, because you want to cover, the HSP genes, the SPG genes, and your neuropathy genes. But even then, we look at the panels first on that, and then look at a larger Mendelium.
Okay, thank you. Of course, there are several more queries, but I think for want of time, Mahesh, would you like to take those questions
yes,
on the chat box?
Yes, Shafra, you want to comment?
No, it was an amazing talk. I think you take on the questions and then we can go ahead. It's really very nice and helpful.
Yes.
Questions.
Yeah, Dr. Denny has asked a question: how to diagnose CMT in infant or toddler besides the genetic risk from the family?
Sorry, can I just have that question again?
How to diagnose CMT? It's in the chat box. How to diagnose CMT in infant or toddler besides the genetic risk from the family?
Yes. So many of our children with CMT, with the very young, won't have a family history, and that's because they have a de novo or a new change, or they have a recessive change. So I would advise you go to we accurately phenotype. It's sometimes hard to do strength testing, so you'll have to see maybe if they have ankle dorsiflexion against gravity. And this is the place where nerve conductions are extremely useful. Nerve conduction studies can be done at any age, from a newborn to 100 years of age. And as long as you have good norms, and there are norms published for those between 0 to 3 months or 3 to 12 months, you can clarify the nerve abnormalities very well on nerve conduction studies, and they are a gold standard. And after that, there is neuropathy. You then go on to doing a panel. There are very good papers published. I'd refer you to Jonathan Bates' paper in Brain in 2011 that looked at very early onset forms of CMT and the various genes that cause CMT in that group.
Second question, what is the role of a neurosurgeon in the management of CMT? Does spinal cord stimulator help? Spinal cord stimulator.
I'll answer that question slightly differently. So there's been a lot of discussion here about if there's any benefit from spinal cord stimulators. I'm not going to get involved in that specific discussion. Let's talk about pain in CMT. For us, children with CMT do complain of pain. It's usually not neuropathic pain. It's usually musculoskeletal pain. Usually the neuropathic pain that we see is more common in acquired forms of CMT. I don't have any expertise in the use of spinal cord stimulators. Our protocol is to make sure they have a regular exercise program to manage their fatigue. They do regular stretching, and then we use pregabalin, gabapentin, amitriptyline to manage any pain with CMT. But usually, if you manage fatigue well, exercise, stretching, pain is usually not a disabling symptom in CMT. That's different to acquired neuropathies. Our orthopedic surgeons do, in carefully selected patients, either multi-level or foot surgery for CMT.
One more question from Dr. Vaishak from Kochi. Can acquired neuropathy coexist with CMT? We had a
Sorry, go ahead. Sorry.
Yeah, we had a 3-year-old boy with typical clinical features of Bickerstaff encephalitis and serum GQ1B positive. Later, when the improvement was not that good, we reassessed and found that mother was also having features of hereditary neuropathy.
Yeah, look, CMT, the most recent papers have shown that 1 in 1,200 individuals have CMT. Then, of course, so therefore, and it's the commonest neuromuscular disorder. So it's not uncommon to have a coexistent acquired neuropathy. Again, it seems that the rate of having a superimposed acquired neuropathy is slightly higher if you have an underlying CMT. So there may be something that makes your nerves more vulnerable to damage. So if you have a child with CMT that's not progressing the usual way, they're progressing too quickly, think of whether they may have a superimposed inflammatory neuropathy, especially if they have the demyelinating form. The other thing to remember is if you see a child with an acquired neuropathy who's not responding to immunomodulation, 80% of children with CIDP, almost everyone with GBS, but 80% with CIDP should respond well to IVIG and the remaining to steroids. So if they are not, we give a 3-month trial, and then everyone goes and gets a CMT panel if they have not responded like we should. But yes, rarely we can see the two combined. What we do in these cases is give 3 months of monthly IVIG and document any improvement.
One more question from Dr. Murali. He asked CMT symptoms similar to DMD. Can both be there in kids?
I guess it can. Again, Duchenne, 1 in 3,000 males. So I think it is possible, but it is a rare combination and genetic testing should help you define that answer, because, you know, if you have Duchenne, then your hit rate on diagnostic testing is close to 95%.
One more question from Dr. Farhan. He has mentioned about a case whose genetic was suggestive of PRX compound heterozygous confirmed by Sanger's and trio analysis. But the patient later developed myelopathy and died due to severe autonomic instability. EMG NCs was suggestive of sensory axonal neuropathy. His clinical course was very progressive. The patient died within 1 year of onset of symptoms. So the question is, have you come across CMT cases with myelopathy and rapid progression? This particular study was negative for adrenomyeloneuropathy.
Yeah, classical CMT doesn't have spinal cord involvement, but we know other forms that have quite common involvement. You know, you talked there about B12 deficiency. Friedreich's ataxia is the common one with spine and peripheral nerve involvement. So this is where I think about phenotyping. Now, periaxin is a common cause of demyelinating CMT. It used to be called a cause of Dejerine-Sota syndrome, which is early onset with very slow conduction velocity. So it's a bit interesting for me that this child had an axonal neuropathy. Maybe that was not the cause. Sometimes, you know, you do get recessive mutations, but maybe they are not pathogenic. And again, severe autonomic instability and myelopathy is not the usual combination for periaxin gene mutations. The one that we have seen with periaxin, early onset, severe, but usually then they are stable through life. So maybe the periaxin was not the cause for this child.
Thank you. We finish the questions from the chat box and both the Q&A. We like to go with the short case presentations. I request Dr. Sharath to share his slides and present the case. Sharath?
Hi, good evening, sir.
Request the experts for the comments in between cases. And Sharad, we had requested for very brief presentation today, right?
Yes, ma'am. It's very brief only. Good evening, everyone. Am I audible, sir?
Yeah, it's audible. Yeah.
Yeah, I'm Dr. Sharath from Indira Gandhi Institute of Institute. From my mentor is Vaikuntaraju, sir. Today, I'm going to present a case about a 16-year-old female child coming from central Karnataka. Came with complaints of weakness of all 4 limbs. Started since 2 years. With the complaints of fever since 10 days, with normal birth and developmental history, with family history of second-degree consanguineous marriage, second child. Brief clinical history is in 2021 or 2022, maybe 2-3 years back, she developed insidious onset chronically progressive weakness. First noticed in right upper limb. Over few next 2 to 3 months, it was progressed to involve the left upper limb also. Causing activity limitation, but it was not so severe to approach the health care attention. Then over next 1 year, it progressed to involve the lower limbs. Yet they have not sought any healthcare attention. Then in the month of August 2023, that is last year, along with fever, she had the first episode of exacerbation in the form of predominant weakness, both proximal and distal, proximal more than distal, causing her to having difficulty getting up from sitting posture, difficulty in rolling over or getting up from supine posture, and also over next 2 to 3 days, she also had difficulty lifting her arms above the shoulder. For which the child was admitted in tertiary care center and was treated as a GPS with IVIG. With IVIG, child had marked improvement within 3 to 4 days. She was admitted for a total of 15 to 20 days. She was almost able to walk independently if made to stand at the time of discharge. So they have concluded it as a GPS and sent her home. Again, within next 1 month, she had second exacerbation. It was almost similar to the first one, but this time it was more severe in the form of she had both proximal and distal weakness, with proximal more than distal. Along with limb and trunk involvement. This time she also had ophthalmoplegia, respiratory difficulty, swallowing difficulty, ptosis was there, with other cranial patches were there. Our hospital, on arrival, she was mechanically ventilated because of respiratory failure, but her consciousness was intact. She was again treated with IVIG. Again, she had a dramatic improvement within 3 days. She improved. She was weaned off from the ventilator within 3 to 4 days after giving IVIG. So that time the working diagnosis was kept as acute onset rapidly progressing flaccid quadriparesis with bilateral element facial palsy with ptosis, with ophthalmoparesis with bulbar weakness, with the significant persistence of chronic progressive weakness in upper limb followed by lower limb. Secondary to suspected the DDs, we have kept it as the GBS with an inadequate treatment. Second one was immune-mediated neuropathies like CADP, multifocal motor neuropathy, or polyneuropathy with monoclonal gammopathy. Third one was Poem syndrome because transiently her TSH was elevated in one of her previous reports, and here also an anti-TPO antibodies were slightly elevated, although there was no organomegaly. The fourth DD was hereditary neuropathies, and fifth one was mitochondrial. Head-to-toe examination was showing ptosis, poor build, poor nourishment, and marked wasting of both distal and proximal extremities were there, with the BMI of less than minus the standard deviation. The higher mental functions of after MMSE score was 23, which was done after stabilization. Cranial nerves, ophthalmoplegia was there with the bilateral ptosis with the reduced facial expression and poor gag and poor shoulder shrugging. Atrophy, marked atrophy of limbs with arching of foot and clawing of hands were there. The tone was reduced in all 4 limbs. Power was around 2/5 across all the joints, both in upper and lower limb. Reflexes were +1 in upper limb and absent in lower limbs. And planters were mute. Some amount of sensory involvement in the form of altered pain and crude touch sensation was felt in the right upper limb more than left. This was after we shifting her to ward. She still had some amount of weakness. She was not able to get up on her own. You can see buckling of her knees and waddling it. By this time, the ptosis, ophthalmoplegia, and facial palsies were all were on the improving trend. Routine investigations were normal with slightly elevated anti-TPO, and ESR was 90 and CSF protein was 82. Cell counts were 100% lymphocytic. Vasculitis profile was negative, and NCV, first NCV which was done in the first admission time, that was also lower limbs were not recordable, and second, third, and fourth was done during second admission, that is in our hospital. That time also it was not recordable in both upper and lower limb, and along with the sensory involvement was also there. MRI was normal. Nerve biopsy was showing inflammatory neuropathy and with the demyelination and axonopathy. Muscle biopsy was normal except for neurogenic atrophy. She was fitting into the features of CADP according to the European Academy of Neurology. She was fitting into mandatory clinical criteria also, along with the electrodiagnostic criteria, with the CSF criteria was also fitting. So we concluded as acute onset rapidly progressing flaccid quadriparesis with multiple cranial palsies with significant persistence of chronic progressive weakness in upper limb followed by lower limb. Secondary to CIDP only we have kept the diagnosis. So after 2 months, she was on mycophenolate mofetil and steroids. Compared to the first video, there was definitely improvement in her weakness, both proximal and distal. She was able to get up from sitting posture. In our institute, in the last 1 year, we have seen 3 cases of CIDP. All are almost the same age group, above the age group of 10 years. All have received IVIG and steroid and rituximab also on maintenance mycophenolate mofetil. Thank you.
Vaikunth, you want to give comments?
Sorry, sir.
Vaikunth.
Dr. Raju, your comments, please.
Yeah, yes, madam. So CADP is one of the diagnoses you should consider whenever a child present with chronic neuropathy. In addition to hereditary neuropathies, as it is one of the treatable condition, and should always consider one of the differential diagnosis before considering and exclude before considering the hereditary neuropathy, telling genetic diagnosis. You should consider this condition.
Thank you. Dr. Manoj, your comments, and then Nandini and Maya.
Yeah, I think fantastic, very interesting case. Now, obviously, this wasn't GBS because there was deterioration after 8 weeks, which is your cutoff for CIDP. The cranial nerve involvement, ptosis, and ophthalmoparesis is interesting. Their studies have shown that cranial nerve involvement is less common with acute onset CIDP compared to GBS, but it still is possible. And I guess you did exactly what you should: give it a trial of immunomodulation, have good nerve conduction studies that show that there's clearly a demyelinating picture. It's just interesting. I was wondering whether she may also have other antibodies. For example, some of it had a myasthenic type of this thing with ptosis and ophthalmoparesis. And that responded, but I think you were on the money with your CIDP diagnosis, and your protocol for CIDP is what we use. We use IVIG, plasmapheresis, steroids, rituximab if you're acutely unwell. And for long term, we use steroids, and we have a preference for using mycophenolate as a steroid sparing drug. So thank you for sharing that case. That's very interesting.
Thank you.
Thank you, Dr. Vaikunth. Interesting case. I know we do keep seeing such patients. We call them as acute presentation of CIDP and in the emergency. So I'm not sure about Dr. Manoj also or Vaikunth. We are sort of uniformly doing MR neurography in our patients, even in children. So when they come with this acute presentation and when we do MR neurography and find thickened nerves or hyperintense nerves or asymmetric nerves, so we tend to make a diagnosis of acute presentation of CIDP like a GBS. So, and also for inherited also we find very uniform thickening of the nerves. And also we are quite now doing ultrasound of the proximal nerves and which is almost similar to MR neurography, and it's much cheaper and more amenable to do in children and pediatric age group. So I don't know if could you do MR neurography on this child or
Oh, madam, in this child, you were not done because child was an acute illness and not much experience about ultrasound of our hospital also regarding nerves. That is also one of the reason. So you were not done.
Okay. Interesting case. Thank you so much. Thank you.
Thank you.
Thank you, Sharad and Dr. Raju for that case. You mentioned that the child had upper limb weakness to start with, because that is a little unusual. That was one odd point. And of course, CIDP generally presents with predominantly a motor syndrome and with proximal weakness. And I think the child had a kind of an insidious course and then had a acute worsening. Of course, the pinching point was
actually, that is not the actually presenting complaint, but only retrospectively
yeah.
after taking history, they are giving that history. So
Okay.
After detailed history, they are telling they are not exactly remember. Most probably it is onset in the lower limb because by examination, looking lower
Yeah,
limbs are more involved. So maybe they are
possible. Yeah,
using
yeah.
more upper limbs. Okay, that is a present thing.
Another thing that we have found useful is, of course, now we don't do nerve biopsies for CIDPs. We tend to go clinical as well as nerve conduction. One of the other points for differentiating between acquired versus chronic is a dispersion, to look for temporal dispersion. So if we see a dispersion, then it is more in favoring acquired, like a CIDP.
Yeah, yes,
So
madam. That is one of the
yeah,
thing during recovery order, but during acute condition as a severe neuropathy, we are not able to differentiate. Yeah,
possible. Yes,
yeah,
yes,
possible.
yes.
Yeah.
Like to add, like Nalini was a nice case, very nicely done. Nalini, you were saying about MRI. Yes, we do MRI in such a situation, and ultrasound. We have been working on ultrasound for these, for the nerves. We've just completed one dissertation we've done for LGB, trying to see and trying to prognosticate the early, doing the ultrasound. So I think that studies are also, that will be good if one starts doing, because that's non-invasive and can be done, even in the sick children, they can be done bedside. Thank you.
Yeah,
Can we go on
thank
to the
you.
next case? Thank you. Can you go to the next case, Manush? Sorry, Mahesh. Mahesh, let's case.
Dr. IPEC? Dr. IPEC eyes? Dr. IPEC? Dr. Diksha?
Good evening, sir.
Yeah.
So can you hear me and can you see
Yeah.
the slides?
Yeah, we can hear you. We can hear you. Okay.
Okay. Hi, I'm Dr. İpek from Izmir, Turkey. Today, I will present you two cases of rare cause of CMT. Here, this is the first case, 8 years old female. He admitted to our clinic with motor delay and gait difficulty. She was able to sit independently at the age of 2.5 years and start to work with sport at 4 years, at the age of 4. Still, she can walk with support and she cannot hold anything with her hands. And examination revealed distal muscle atrophy with weakness, areflexia, scoliosis, strabismus, and osteoporosis, and mild intellectual disability. And her CK was normal, craniospinal MRI was normal, NGS showed axonal sensor motor polyneuropathy, and PMP22 MLPA was normal. And this case was published in 2017. This is an old case, and at this year's our CMT panels were including a few genes. So after this MLPA test, we had to go on with West analysis. And this is the second case. He's a 6-year-old male. Again, he was admitted with motor delay, speech delay, and gait difficulty. He also suffered from neonatal complications with respiratory insufficiency. Also, he had infantile hypotonia. Again, he had had control at 4 months. He was able to sit at the age of 1, able to walk with support at the age of 3, and his first words were start at the age of 3. And his examination also showed that predominantly distal muscular weakness in upper limb and lower limbs, also skeletal muscle atrophy, again predominant in the distal muscles, and also areflexia, scoliosis, and mild intellectual disability with learning difficulties. His CK was normal, MRI was normal, and again his NGS showed axonal sensor motor polyneuropathy with neuropathic MUPs in his needle EMG. And at this time, a wide neuromuscular panel we can perform. And both patients' panel and West analysis revealed homozygous like the pathogenic variants and MCM3AP genes. It takes PM2 because for population data because it was almost absent in genome at And many prediction tools show the destructive effect of this variant on the protein. And when we focus on the change amino acid, we see that it's in a domain region that plays role in protein-protein interactions. So the diagnosis is CM3AP related Charcot-Marie-Tooth with or without intellectual disability. Here I will have to talk, give you brief information about MCM3AP gene and its CMP condition. MCM proteins are involved in the inclusion of genome replication. They are, we can say that they are key component of the replication complex, and they are totally involved in the formation of replication folds and the restriction of the other DNA replication related proteins. They act as a replication facilitator, and MCM complex also has a helicase activity, and this protein also interacts with and is circulated by MCM3AP. It's a associated transferase. And this selection of this protein it's the initiation of DNA replication cells cycle progression. And also immunostaining analysis detected that localization of MCM3AP network envelope, which is consistent with its role in core complexes. It also reflects the transfer of mRNA from nucleus through pores. And GAMP is an alternative splice variant of MCM3AP. It has 4 domains, and here the most important domain is the SAP3 domain. It takes role in exporting membrane cytoplasm through the nuclear pores. G and E dysfunction affects the replication and transport of mRNA. This is the fourth MCM3 related neuropathic cases that was reported in 2020. Here, in a brother and sister peripheral neuropathy with impaired intellectual development, there was it was identified a homozygous mutation in the MCM3 gene, which was affecting a highly conserved residue in the SAP3 domain. And in 2017, 9 patients from 5 unrelated families were reported. All had affected with intellectual disability. Their patients' ages range from 3 to 28, and besides neuropathic and intellectual disability, hypotonia, motor delay, sensory hearing loss, progressive causes of ambulation, or other findings in this report. And here you can see some of these features of these 9 cases in this report. Initial features included hypotonia and mild delayed motor development, with most patients expecting by age of 2. And almost all the patients lost independent ambulation between 10 to 24 years and between YG1. All patients had evidence of sensory motor peripheral neuropathy, and most had spinal collapses.
IPEX network is not very good, isn't it?
Yeah.
Your audio is not very clear. I don't know.
Can you hear
Mahesh,
me
what
now?
did you say?
Yes, my audio is not very clear.
We're not very clear.
Not IPAC?
I think there is a problem with
Yeah.
our internet connection. So
Would you like to summarize the case? Yeah.
So is there a general problem or?
It's only with her, I think. That's all fine.
We can hear Dr. Eulis, but we can't hear the speaker.
Yeah.
Okay, I think she almost completed her presentation. So if it's okay for you, I can make the comments for
Yeah, that's better.
Okay. So in Turkey, due to high levels of consanguinity, we have lots of patients with CMT, and in our university, in our pediatric neurology department, we have more than 200 patients with hereditary polyneuropathies, and CMT, especially the axonal forms, are the most common. And we have patients with axonal polyneuropathies due to mitofusin 2 mutations in our population. But typical expected mutations are rare, and we frequently encounter polyneuropathies as a part of complex and multisystemic diseases as presented by IPEC. So we have lots of cases with metachromatic leukodystrophy, Krabbe disease, and spastic paraplegias, spinocerebellar ataxias, and the coexisting polyneuropathies. So this is one of the cases with a complex phenotype, and the cases had axonal polyneuropathy among with mental retardation and sensor ataxia. So in developing countries like ours and India and other parts of the world, in which the consanguinity level is high, so if we have a pediatric patient with polyneuropathy, so we also have to think about more complex phenotypes. Thank you.
Dr.
I'm
Manoj?
sorry, there was a problem on my internet connection.
Yeah.
I have two more slides. Can I go?
Okay, you can share them. You can share.
This was here you see that we had presented our case in this publication here for patients from 3 unrelated families with identified homozygous or compound heterozygous mutations in the MCM3 gene. And this is the latest publication about MCM3AP variants. Here we can divide into two classes MCM3AP variants. The first is missense variants in SAC3 domain, and the other is compound heterozygous variants outside the SAC3 domain. And here, this graph is from this report, a map of MCM3AP variants investigated in the study. And immunochemistry investigation sought reduced abnormal nuclear localization of GNMP in patients with SAC3 domain variants, and in patients with variants also out of this domain usually come with more severe and more complex clinical features. And here in function studies, it was shown that GNMP was disrupted in immunostaining studies. So as a conclusion, it's an mRNA export scaffold protein, and it causes a childhood onset complex neurological disorder predominantly with early onset peripheral neuropathy with or without intellectual disability. The main features are distal motor weakness, gait difficulty, and mostly electrophysiological studies showed axonal sensorimotor neuropathy, and additional features can include ataxia, motor neuron size, or eye abnormalities, and etc. So thank you. And I'm sorry for the internet connection.
Dr. Manoj, your comments?
Thank you for that case. I don't have a case of, I've never seen a child with MCM3AP, so I can't comment on that phenotype. There was an Australian case in that group, but that was from Melbourne. All I can say is it shows the benefit of very good phenotyping. So here's a complex genetic syndrome, intellectual disability, ophthalmoparesis, and ptosis is uncommon in CMTs. So it's apart from MTMR2 and MTMR13, I think so. Here you put together a complex syndrome and then your genetic testing has nicely found this thing that correlates well with that and the nerve conduction study. So interesting case.
Well, Mahesh, you may proceed. No comments
Yeah,
from my
proceed
side.
with the next. Yes, yes. No comments, please. Yeah.
Good evening, sir. Should I start with my presentation?
You can share your slides, Diksha.
Okay. Am I audible and my slides are visible?
Yeah, that is it.
So good evening, everyone. Today I'm sharing a case who presented to us with auto amputations due to an underlying neuropathy under the guidance of Dr. Pradeep Kumar Panda, sir, from AIMS Rishikesh. So coming to the details quickly. So we had Master S, 13 years old boy, resident of Haridwar, who's currently under a follow-up in OPD. And he presented to us with the complaints of auto amputation of toes and multiple ulcers on bilateral foot for the last 1.5 years. So it all started with the history of lack of pain and temperature perception on bilateral foot, followed by skin changes like dryness and thickening of skin. It was followed by cracking, leading to formation of non-healing ulcers, followed by eventually auto amputation of the toes. He also had history of new onset fever spikes, ankle swelling, non-healing ulcers with purulent discharge and recurrent abscess formation since the last 1 month. And also there was new onset joint deformities and multiple painless recurrent fractures. There was no history of trauma, seizures, any vision or hearing impairment, excessive or reduced perspiration, lack of tears, intellectual disability, or any bowel or bladder incontinence. And the child was born of a non-consanguineous marriage, and there was no history of any auto amputation or similar illness in the family. Coming to the clinical examination, as we can see that there was auto amputation of almost all the toes with overlying skin changes like hyperpigmentation and scars and multiple non-healing ulcers and shortening of the phalanges and the metatarsals as well. Apart from that, we could see that there are joint deformities, but there was no gangrenous changes, and the peripheral pulses were well palpable, suggesting underlying vascular etiology to be less likely. There was no corneal ulceration, dry eyes, nail changes, tongue changes, or absent fungiform papillae or hyperpigmented patches or any peripheral nerve thickening. Coming to the CNS examination, his higher mental functions, cranial nerves were intact, tone and power were normal in all 4 limbs. However, the reflexes were absent. In sensory examination, the superficial and deep sensations were markedly reduced, specifically in the L5, S1, and S2 dermatomes, and the cortical sensations were intact. We upfront kept the possibilities of hereditary sensory autonomic neuropathy, especially type 1A, 1A, 1C, 1D, and type 2A, as they commonly present with auto amputations, non-healing neuropathic ulcers, sensory neuropathy, joint deformity, and painless fractures. And there was nothing against it. In Hansen's disease was also considered as it is a treatable cause, and auto amputation, neuropathy, and joint deformity can commonly present with Hansen's disease due to Hansen's disease, with no peripheral nerve thickening or no hyperpigmented patches, making it lesser on the cards. Other possibilities of sensory neuropathy like toxic neuropathy, CIDP, and diabetic neuropathy were also considered, but they usually would not have presented with auto amputations. So we had considered them less likely. In investigations, the routine and the RBS was completely normal, and slit skin smear, which was done for lepra stain, was negative. Ultrasound bilateral lower limb with Doppler was done, which was normal with normal flow, suggesting vascular etiology, again less likely. Now, we also had planned a nerve biopsy, but it could not be done as the child had ankle swelling and multiple abscesses, limiting this study. NCS was done, which showed normal motor amplitude and conduction velocities in bilateral median and ulnar nerves, and the sensory nerves were, however, completely not recordable, suggesting sensory neuropathy. In the X-rays of bilateral foot, we could see that there was intertarsal and metatarsal and calcaneal subluxations. There was lytic lesions, and there was lytic lesions and bony destruction of the toes of the phalanges and the metatarsals. And also we could see that there was bony segments in the subcutaneous tissue, and there was diffuse osteopenia. Apart from that, here we could see that the second and the fifth toe had corticated tapering ends, which is suggestive of licked, like a candy licked appearance. So this licked candy appearance is basically seen in neuropathic joints. So this X-rays were also suggestive of a neuropathic joint. Meanwhile, the next generation sequencing report had come, which had shown that there was a homozygous 2 base pair deletion in the exon 9 of the W and K1 gene, suggesting the diagnosis of hereditary sensory and autonomic neuropathy type 2A. We had managed the child conservatively. Appropriate intravenous antibiotics and wound care was done, and shoe and socks care, need of hydration and prevention of injuries was also explained. So briefly touching upon this topic, HSN type 2 has 4 types according to the underlying genetic etiology, and WNK1 clinically also fits into our child, as we can see that the autonomic involvement is not usually seen in the type 2A. However, the autonomic involvement can significantly be seen in the type 2B and type 2D. Similarly, HSN type 1A, 1C and 1D can also present with auto amputations, and but they can have episodes of lancinating limb pain, and like our child had painless recurrent fractures, and also there was no anhydrosis. Apart from HSN 1 and 2, HSN 3, 4, 5, 6, and 7 has also been commonly reported, but they can also present with loss of pain and temperature sensation, but usually they will have a onset at neonatal onset or an early childhood onset, which was not so in our case. So I would like to conclude that we were dealing with a child with HSN2, which we managed conservatively. And the take-home message is that even without any autonomic features, we should always consider possibilities of HSAN, and we should always rule out Hansen's disease in adolescents, especially because it is a treatable disease. Thank you.
Dr. Pratik, like to give your comments?
Sir, the only thing is, I think the nerve conduction study in this child also showed absence of all snaps, sensory nerve action potentials. That actually didn't confirm the diagnosis, but it was not favoring more towards Hansen's, as the motor action potentials were recordable. That was the only thing I wanted to comment, sir.
Manoj?
Excellent case, and it shows how to bring about a differential in the hereditary sensory and autonomic neuropathies, other than type 3, which is Riley-Day with prominent autonomic involvement. Type 1 and type 2 are large fiber neuropathies. So you saw, and predominantly sensory. So you saw the sensories were absent. Type 4 and 5 are again early onset childhood, but they are small fiber neuropathies, and nerve conduction studies are normal. So you identified that it was a predominantly sensory neuropathy, so HSA, and then you showed that the sensory snaps were absent. So really you had narrowed it down to HSAN 1 and 2, and then you found a gene that causes in HSAN 2, but that's an interesting case. Thank you.
Dr. Maya, Dr. Lini?
Yeah, actually, this child, because of the severe sensory involvement, as we could see, it was a typical Charcot joint. And the main treatment, of course, is, prevention of injuries. And we need actually very good rehab and orthopedics involved in the care of these children. Yeah, that's... Could you do a SSR on this child, Dr. Manoj? Sympathetic skin response, would that help, or it's just clinical would be good enough?
We used to do it a lot for diagnosis of our 4 and 5s. Now we have stopped doing sympathetic skin responses because genetic testing in this group is so, it usually shows us a cause. Ours, we have a lot of children with 4 and 5. I don't have one with 2A yet, but we don't use the sympathetic skin responses anymore. We just we do the nerve conduction studies, see if it's a large or a small fiber neuropathy, and then go off for genetic testing.
Dr. Nalini?
Yeah, interesting case. Yeah, we also had recently a case of WINK1. In fact, the nephrologist referred the case with, the picture was typical as what was shown here, and the renal biopsy had showed amyloidosis. So we were quite wondering whether this boy was a 28-year-old boy with onset from early childhood. So we thought, are we dealing with the case of amyloidosis? But then when we did the genetic testing, it was WINK1 mutation, homozygous. But I think it was due to the severe infection and recurrent chronic osteomyelitis infection that he had gone in for a secondary amyloidosis and developed a nephrotic syndrome. So there was a little intriguing case that we recently had. I mean, just planning to write it up. Yeah. So thank you. It was a very interesting case.
Thank you, ma'am. We move to the next case. Request Dr. Aishwarya to share your screen.
Is my screen visible, sir? Am I audible, sir?
Yeah, you're audible. Please share your screen.
Can I start, sir?
Share your screen.
Screen is not visible, sir.
No. But share your screen. Share. Green button is a green button. Yeah, make it full screen.
Okay, sir.
Yeah, fine.
A
It's
very
clear
pleasant evening, one and all. I'd like to thank my guides, Dr. Ranjit sir and Dr. Ritik sir, for giving this opportunity. To begin with the case, we have a 23-year-old female born out of non-consanguineous marriage, presented with complaints of involuntary movements of upper limb since the age of 5 years. The child had myoclonic jerks gradually, which increased in frequency. Initially, the child had 1 to 2 jerks per month, which progressed to almost 10 per day in a span of few years. It also progressed to involve all 4 limbs. It was not associated with any triggers. There was no particular association with any acoustic or tactile stimulus. There was no history of loss of consciousness. At the age of 10 years, she was noted to have recurrent falls with tripping of toes and frequent slippage of footwear, which gradually progressed to bilateral foot drop, requiring foot splints. At the age of 11 years, she had difficulty in climbing stairs and difficulty in getting up, suggesting proximal weakness, with upper limb distal weakness, with difficulty in buttoning shirts and gripping of things. By the age of 15 years, she required a wheelchair for mobilization. She had a significant family history. The younger brother had developmental delay with myoclonic jerks and distal predominant weakness in all 4 limbs since the age of 7 years. On examination, head to toe revealed short stature with clawing of hands and pes cavus foot deformity. The MMSE score was 26/30. Motor examination revealed hypotonia in all 4 limbs with diminished reflexes. Upper limb power was 3/5 in both proximal and distal, with lower limb proximal power of 2/5 and distal power of 1/5. Trunk and neck muscles were normal. Sensory examination revealed only mild impairment in vibration and joint sensation. The differential diagnosis we had in mind was mitochondrial MERRF, spinocerebellar degeneration, renal failure action myoclonus syndrome, progressive myoclonus epilepsy types. Coming to the investigation, the blood routine, which include a complete hemogram, RFT, LFT was normal, ECG done was normal, echo was normal, CPK levels were normal, NCS done at age 17 revealed sensory motor axonal neuropathy with normal VEP. However, a repeat NCS done showed no recordable parameters. MRI brain and whole spine was normal. EEG done earlier showed epileptiform discharges, for which she was started on anti-epileptic drugs, but the repeat EEG done now was normal. We went ahead with genetic analysis. The genetic analysis identified a heterozygous missense variant in exon 7 in ATL3 gene that resulted in amino acid substitution of serine for proline at codon 245, which is a damaging variant. Sanger sequencing of the brother and mother showed heterozygous variant similar to the subject, but the father had a wild type. ATL3 gene mutations till now reported have been associated with hereditary sensory neuropathy type 1F, which usually presents with significant sensory complaints and ulcers, but our patient presented with other features like myoclonus and short stature. The take-home point we would like to convey from this presentation is if a patient presents with features of neuropathy along with myoclonus, we need to consider hereditary sensory motor neuropathy with ALT3 mutation as one of the differentials. We thank the patient and parents for their cooperation in the study. These are my references. Thank you for the opportunity.
Ranjit? Dr. Ranjit?
Yeah, thanks, Dr. Aishwarya, for this quick presentation. So this was a case shared by our adult neurology colleague because the boy had boy was a pediatric age. So the list of differentials which Dr. Aishwarya had shown, or the differentials, should be considered when you have myoclonus or neuropathy-like presentation. So this gene ATL123 is a set of genes involved in the regulation of endoplasmic reticulum. And this ATL3 is a ubiquitous protein expressed in the brain as well as in neuropathy and as well as in nerves. So, so far this myoclonic kind of a presentation has not been reported, although ATL3 has a myriad of spectrum of presentations. So we thought whether it is a novel presentation of this gene, and open to hear comments from the experts and including the adult colleagues.
Dr. Manoj?
Yeah, I find this is very interesting. And I just wanted to ask if you have written it up, because I had a case maybe 5 years ago with exactly the same phenotype, myoclonus, ATL3. We did sequencing at Miami. We found ATL3. We just couldn't get it above the line for publication because it's been described as causing either HSP or a sensory neuropathy. But she also had myoclonus and exactly the same picture. So that's interesting. So maybe I'll talk to you and we can put both these. If I can find this thing, put them together, because I couldn't find that phenotype. So I'm just interested, have you found other reports of exactly this phenotype?
So yeah, so we did a quick literature search. I couldn't find any reports. So that's why we're a little skeptical whether this myoclonus followed by this neuropathy presentation is a novel one, or we're missing something else. Now that we hear a similar presentation from you, I think we should write it up for sure.
Okay, let me see if I can pull this thing, and I'll get back in touch with you, Ranjit. That's excellent. Thank you.
Dr. Nalima? Dr. Mayan?
Excellent case, Dr. Aishwarya, for presenting this. Learned something from this case and the presentation. We will look in our cohort also whether we have this gene and whether the presentation, and we will definitely get back to Dr. Manoj and to you in case we find any. Maybe have about 150 plus CMT confirmed, and we'll just have a look at the genes with us. Thank you.
Yeah, thank you. I guess, as you mentioned, it's ubiquitous, this gene representation. So I'm sure we'll probably see this expanding phenotype. Yeah, that's.
Thank you, ma'am. Now move on to the next case. Request Dr. Jyotsna to share her slides.
All the presenters will be mailed their participation certificates. Huh?
Yes.
And I wanted to put on record that Ranjit's titles are very exotic. For all the presentation of his students, all the titles are very exotic. And I wanted to take out a list of all the exotic titles in the last 1.5 years.
Jyoti can start. Thank you.
Yes, sir. So am I audible and my screen is visible?
Yeah, you're audible. Screen.
At the outset, I thank the AOCN for this opportunity to present this very interesting case where we gave precision treatment in a child with peripheral neuropathy. 11-year-old girl born to non-consanguineous parents, presented with an asymmetric distal weakness and wasting of bilateral upper limbs. As we can see, there is significant wasting in both the intrinsic muscles of the hands. NCB showed reduced CMAP amplitudes and conduction velocity slowing in the and the EMG showed a neurogenic pattern. 2 years she was lost to follow-up after this presentation, and 2 years later she presented with a further progression of weakness in her hand and wasting of the hands, which had progressed, and there was a recent onset of weakness of proximal lower limbs over a few months, and she also reported a change in gait. An interesting finding that was noted on the examination, apart from the expected sluggish knee and ankle, was that her upper limb reflexes were brisk and plantars were upgoing. And she was also noted to have a mild spastic ataxic gait, which was apparent on walking. NCV follow-up 2 years later showed worsening of the conduction parameters of the already involved nerves, and some proximal lower limb new onset involvement was there, and the pattern was of a mixed axonal and demyelinating type of neuropathy. EMG again was done, which showed a neurogenic pattern. So at this point of time, it was obvious that we were dealing with a multineuraxial syndrome, which had a definite predominant element component in the form of an upper limb onset neuropathy. But 2 years into the onset of illness, there were definite UMN findings, brisk upper limb reflexes and extensor plantars, and a mild amount of ataxia and spasticity, which suggested a definite multineuraxial syndrome. An extensive workup was done to rule out acquired etiologies. MRI, blood, CSF routines were all normal. Vasculitic workup was negative. But at this point of time, because of this unique pattern of neuraxial involvement, a genetic etiology was thought of. And a genetic evaluation after consultation with geneticist was positive for this SLC5A6 mutation. The SLC5A6 is a gene that encodes for the sodium multivitamin transporter. This transporter is a membrane protein, and it helps in the sodium dependent uptake of vitamins across the cell membranes. And there are solutes that are specific to this sodium multivitamin transporter. They are the biotin, pantothenic acid, and alpha lipoic acid. And clinical manifestations simulate the respective vitamin deficiency. And in this case, it was the biotin, pantothenic acid, and the alpha lipoic acid deficiencies. It comes under the broad spectrum of transportopathies. So a precision treatment was initiated with those specific vitamins. High dose biotin, alpha lipoic acid, pantothenic acid was started, which resulted in a significant improvement. This is a video of the child who came to us 2 years into the onset of illness when she had started with this lower limb weakness. And we can find that the child has significant difficulty in rising up from the kneeling position, showing a proximal lower limb weakness. And this video shows 2 years into the treatment of high dose multivitamins, which shows a significant improvements in this lower limb weakness. There was no major improvement in the wasting of the hand muscles, but the child reported a significant improvement in her handwriting and her hand grip, especially while writing. There was an improvement in the nerve conduction study parameters. And this was reported as a part of a multicentric cohort, and 3 of the children in that cohort were from our institute. The take-home message from this disease is that the treatable neuromuscular disorder spectrum is expanding exponentially. A precise genetic diagnosis is expanding the possibility of precision medicine by leaps and bounds. And that is very nicely exemplified this case where the child's quality of life had a profound change after the initiation of vitamins. We thank the genetic team and our team for this collaborative effort. Thank you.
Vinyan sir, your comments, please.
Yeah, nothing more. She has presented it well. See, the point here was initially when we presented an upper limb onset neuropathy or a motor neuron disease was considered because the reflexes were a little brisk with the wasting of the hand muscles at that point. So a restricted motor neuron disease or a motor neuronopathy was the first thought. But then after 2 years, when they came up after the Ayurvedic treatment and all, then it became a kind of a multi-axial neurological syndrome with spasticity, ataxia. So we are not able to put a specific neurological syndrome at that point. And luckily the genetics helped and she has improved. So the message here is, even though we started initially with low dose, the cofactors, the diagnosis, the genetic diagnosis, after the genetic diagnosis, we actually hiked up the dosage and we added the alpha lipoic acid, pantothenic acid and all, which actually made the difference, I think. So the basic message is, even though we are treating with the cofactors many times, the genetic diagnosis will make us more confident and in increasing the dosages. So that is the message I'll say here. Thank you.
Dr. Manoj, your comments?
Yeah, can I just take the liberty of giving two comments? I know it's late for you guys, but two interesting things. Firstly, when you presented the case with predominant upper limb weakness, I wondered if it could be a different transporter, riboflavin transporter deficiency. We have a great interest in that disorder, but of course, there's no demyelination there, and sensories are more predominantly involved. But again, it's one with the precision management. So I guess these are the two things to think about treatable inherited neuropathy. So that's very interesting. Secondly, very interesting, we just had a paper accepted for a group of children with exactly this biotin transporter recently. It's not up on PubMed yet. So they had exactly the features that you described: upper limb predominant, exactly that wasting around the thenar eminence that you showed, and a dramatic improvement initially with intravenous and then with oral supplementation. Now, the interesting thing was both the patient that we had, their uncle, and the other one in our group were from Kerala. And I think you guys practice in that location too. So I think there is a founder mutation for this transport. There we looked at the alleles on this thing, but we couldn't this thing. But I'll get back in touch with you because I think there is a founder mutation in that population there that has a high allelic frequency in the general population for recessive variants. But that was very interesting. Thank you.
Yeah, thank you, Manoj, for that. And one more thing to add, recently that we are following up this child, and with an infection, she had actually a worsening in the conduction parameters, worsening in the overall symptoms. So she was going steady for almost last 2 years, but there was a sudden worsening recently with tremors and all these things. So again, a kind of very weird syndrome, which we are not able to place into the classical neurological patterns.
Yeah, but exactly now that's exactly what our boy has done. He had an infection and came back with tremors, and we repeated the nerve conduction studies because everybody was worsening. Everybody was worried, and we weren't sure whether it was true worsening. But now listening to you, it looks like this is part of the syndrome. So it's fantastic to hear that. So look, now it makes me more confident that this is exactly, he again deteriorates with infection.
Thank you.
Thank you everyone for wonderful cases. It's customary to request the speaker and experts for one more case. One more case left. Okay, I thought it was the last one. Okay, so sorry. Who's the last one left? Huh?
Dr. Harika.
Okay.
Dr. Harika. Make it to full speed.
Is it visible, sir?
Yeah, it's visible. You're audible. Yeah. Go ahead.
Good evening, everyone. We are presenting a case of hereditary neuropathy. 11-year-old male child, resident of Raipur, brought with the complaints of developmental delay since birth and difficulty in walking since 3 years of age. Developmental history is as follows. Gross motor neck control was attained at 8 months, rollover at 1 year, and sitting independently at 18 months, and walking without support was attained at 3 years, and climbing states with support of railing with 2 feet per step was attained at 4 years, and whereas fine motor, language, and social milestones were attained as per age. So it is sized to a motor developmental delay. Difficulty in walking, noticed since 3 years of age. Parents notice swaying to either sides while walking, but gets increased in dark. Initially, it was not associated with falls, but now he falls while walking multiple times a day, and these are not associated with any injuries. Initially, he used to walk independently, now using wall support to walk around his house. Difficulty to get up from sitting position, requiring support of both hands over ground. Difficulty in getting up from supine position by turning to side, and difficulty in climbing up and down stairs, uses side rails. And He is able to lift arm above the head to comb his hair, mix food, button and unbutton by himself, grip footwear without slipping. No history suggest of cranial nerve involvement. No history of diurnal variation or weakness or worsening with febrile illness or easy fatigability. No history of any wasting of muscles or contractions. No history of any sensory disturbances. No history of involuntary movements, excessive sweating, bowel and bladder disturbances, pain in the back. No history of seizures. And family history, he was born out of a non-consanguineous marriage, first in birth order. And there is a history of motor delay in the sibling who is now 1-year-old boy with developmental age of 8 months now. And there were no significant perinatal issues. And on examination, he was conscious, oriented, and his vitals are stable. And on general examination, lumbar scoliosis was present, and higher mental functions, memory was intact, and speech was normal, and cranial nerve examination was normal. On motor system examination, there is a wasting of distal muscles of lower limb, and generalized hypotonia is noted, and proximal muscle weakness of lower limb is more than that of upper limb, and truncal weakness is noted. And DTS are absent, and superficial reflex are also absent. On sensory system examination, there is impairment of vibrational proprioception sensation, and pseudoarthrosis is noted. And gait, there's a waddling gait, and Romberg sign is positive, and Gower sign is also positive, and cerebellar signs are negative. And on spinal examination, lumbar scoliosis to left is noted. This is gait. So here we see there is swaying to either sides while walking. And he is looking down when moving forward. And stretching out of hands, we see pseudoarthrosis. That suggests of impaired proprioception. So to summarize, he is a 11-year-old male child with motor development delay, now with plateau, with chronic progressive proximal muscle weakness, lower limb more than that of upper limb involvement, and truncal weakness, and with distal muscle wasting, and generalized hypotonia with areflexia, and impaired vibration and proprioception sensations, with sensory ataxia, and with history of motor developmental delay in sibling. So our differentials were hereditary neuropathies, motor and sensory neuropathy, with points in favor being with sensory signs more than that of symptoms involving large fibers, and motor weakness with distal wasting and areflexia and scoliosis. The points against are no foot deformities, and proximal weakness is more than that of distal. And we consider mitochondrial also because of polyfocal involvement with features of both the myopathy and neuropathy, and but the points against are no other system involvement. Other differential being SMA type 3, with points in favor being progressive proximal muscle weakness and areflexia and scoliosis, with points against being age of onset and large fiber sensory neuropathy. So we have done nerve conduction studies that was suggestive of absent compound motor action potentials and also sensory nerve action potentials, so both upper limb and lower limb. And whole exome sequencing was suggestive of PRX gene homozygous mutation, which was autosomal recessive, that was suggestive of CMT type 4F, with the symptoms being that was onset being in early infancy. It is residence Otter's disease phenotype. And the other thing is the sibling genetics report has also come that was suggestive of same mutation. So our final diagnosis being chronic progressive demyelinating sensory motor neuropathy, with etiology being hereditary and Charcot-Marie-Tooth type 4A. These are the other case reports that we have found in database, which have clinical presentation of with early onset with sensory involvement and also motor involvement, and NCS which were suggestive of absent both CMAPs and sensory action potentials. So our take home message is any child with proximal muscle weakness, we should not we should also consider neuropathy if sensory involvement is also there. Thank you.
Thank you, Erika, for a very nice case. I'd like to invite comments from Manoj and the other experts. Manoj.
Dr. Lokesh Lingappa, is he there? Dr.
Sir is
Lokesh?
No,
Sir is
ma'am.
not.
Sir is
He's not there. Okay. Okay. Is Ramesh also there? No, he's not there.
No, no.
no, ma'am.
Okay. Then it's Dr. Manoj. Dr. Manoj.
I think interesting case, classical
Stop sharing
presentation.
your slides, Harika.
Interesting presentation, early onset severe demyelinating neuropathy. My only comment is sometimes when we don't get a response from a peripheral nerve, we would do a very proximal study, sometimes to the tibialis anterior or even along the facial nerve, so that we can calculate a conduction velocity. But that's a nice case of an early onset severe demyelinating neuropathy, though you couldn't have told demyelinating initially because you didn't get any responses on your motor studies.
Thank you, Manoj. Dr. Nali ma'am and Dr. Maya.
Yeah, interesting case, of course. Yeah, we keep saying we have a family of this PRX and 4 members. But what was interesting was these patients had severe tongue fasciculations also and wasting of the tongue. And the picture was like a mixed sensory and a cerebellar ataxic syndrome. So the bulbar manifestations were quite unusual, and all the 4 siblings had the bulbar manifestations. And the younger one was the most severely affected with phenotypic variability. So interesting. And of course, we used to call it as Digerent Sotas, and now it is a PRX. When we were residents, we were very much interested when we saw severe demyelinating neuropathies in young infants or young children. So interesting, the genetic evolution, and it's a revolution for us. Thank you. Thank you. Interesting case.
Thank you. Maya.
Yeah, thank you, Harika, for demonstrating, 2 very important signs in those 2 videos. Significant sensory ataxia and the pseudoathetosis. That was a good learning point. Thank you.
Thank you.
Thank you all the presenters for a wonderful session. You all will be mailed your present the certificate. Now, as customary, I will request the speaker and the experts to give take-home messages. And Dr. Vinay and you also. Yeah, Dr. Manoj, first you take-home messages for people.
Look, thank you for having me. I certainly learned a lot from being here. My only comments are very good phenotyping. You saw in all those cases, excellent phenotyping, and then nerve conduction study is a good clinical exam. And usually it helps you then make sure that your target your genetic testing. So that's my only comment. Again, remember the treatable neuropathies. I think the riboflavin transporter or the biotin transporter is important. So yeah, it was an excellent presentations. Thank you.
And I want to express again heartfelt gratitude. It's 2:30 a.m. for you, and really heartfelt gratitude for being here. And Nalini and Dr. Maya, your take-home messages, please.
Yeah, thank you. Thank you for inviting me to be part of this wonderful group. And I learned, Dr. Manoj, thank you. Thank you for your presentation. And of course, and as the previous generation, I always tell the current generation that please be perfect with your bedside phenotyping. There is no genotype without phenotype. So I don't want, and I don't believe in reverse phenotyping. So you do a genotype and then look at the phenotype. So let's go forward, do a thorough bedside clinical evaluation, which is sort of missing a bit with the current, fast world, I think. But because genetics is available, and if it's negative, they don't know what next, what to do next, And so phenotyping and then genotyping is wonderful. And I think all of us jointly have learned from these cases. And of course, genetics has done a lot of teaching and learning for us, but still there's a lot more to learn. And the other thing is only that acquired neuropathies overlapping with the inherited neuropathy should not be missed. I see patients with inherited neuropathy with an acute worsening because of a pregnancy or a fever, receiving immunomodulation for years together, 5 years, 6 years on IVIGs and mycophenolate and rituximab. And one keeps on very wishful thinking that the patient would have a reversible disorder, but then I think they respond very minimally, and we should look for inherited neuropathies in these cases and examine the family members also and the siblings for any evidence of skeletal markers and other markers which will tell us that it could be a inherited neuropathy. So thank you very much for inviting me, Dr. Shefali and Dr. Mahesh, and wonderful session. Thank you.
Thank you. And I think I will reiterate what you were saying and what Dr. Manoj is saying. It is very important, your history and exams is important, and 3 generation pedigree is important. And for neuropathy, it's not the history of family history you won't get. You'll have to examine the family members. That is somehow this neuropathy family history is a bit different from the others, because you'll have to actually examine, because they may not be having complaints, apparently in certain situations. So examination of family members becomes important in this situation. And obviously your electrophysiology comes after that, and genetics obviously after that. Dr. Maya.
Thank you, Dr. Shefali and Dr. Mahesh. And thank you, Dr. Manoj, for that wonderful talk. And as was very clearly demonstrated in his, expressed in his talk, treatment, we are very good at making diagnosis, but how important it is to follow up these children and involve multidisciplinary care, the allied health, the physiotherapists, the occupational therapists, PMR. I think that's something which we should never forget. And of course, there are good therapies in the horizon, but the hope is involving all these allied health specialists in the care of these children. Yeah. Thank you.
Thank you. Thank you. Vinan?
Nothing more to add. Learned a lot. Thank you. Thank you, Manoj. Thank you, everybody.
Raju, you want to say something? Raju. Raju is
Why
still
couldn't-
sitting in his clinic, seeing patients. Mahesh, back to you. Anything you want to say? Yes.
No, it was a really nice talk, and all the 6 pieces were very nicely presented. Each one had a very good message.
Yeah, very, very, very nicely presented, and very, very good. And but again, thanks again to Dr. Manoj, 2:30 a.m.
Yes,
Thanks
ma'am.
a lot. Yeah.
Thank you so much.
It was worth it. It was worth it. So thanks very much.
Thank you.
Good night to
Bye-bye.
everybody.
Thank
and
you
good
so
morning
much,
to
and
Dr.
good night.
Manoj. Bye bye. Bye all of you.
Thank you.